Hi, everyone, and welcome to the first Harnessing the Power of Data in Health scientific track. We're super excited to be sharing this session with partners with Exemplars in Global Health. My name is Amel Guila, and I'm from the Quantitative Sciences team at the Bill and Melinda Gates Foundation. So this session is really going to focus on some of the work we're doing on the data science grant challenges and also the work Exemplars in Global Health are doing. And the focus is really on how do we use data to inform interventions. So we'll be focusing on vaccine coverage work and how data could inform intervention on the ground. I have the pleasure to be co-chairing this session with Amy Mabry from Exemplars, and we also have Steve Kern and Gloria Ikelesi. I promised I won't mispronounce her family name, but I think I did. And with that, I'll hand it over to Amy.
Great, thanks, Amel. Hi, everyone. So I'm Amy Mayberry from Exemplars in Global Health. For those of you who don't know us, Exemplars in Global Health is a group of partners really with the mission to look at identify positive outliers in global health. And our goal is that by working together to analyze what's worked well in those countries, but then also disseminate and work with country partners to adapt those lessons, we can really support in-country partners, global decision makers, funders, to use that evidence and actually learn from what's worked well in the past. So I'm really excited to be here today with the Knowledge Initiative Grand Challenges team and all of you, as well as our excellent presenters and panelists, really to focus on this question of vaccine delivery and look at these different research approaches, these complementary efforts that will be presented today, but also move the conversation to what next and how do we support the uptake and use of the evidence that's being generated. In a minute, you'll hear from Gloria Ikelesi on my team. She'll introduce our Exemplars in Global Health researchers. But in the meantime, I'll hand back to Amel to introduce the KiGC researchers. Thanks.
So as Amy said, we're going to start with a few examples from KiGC, then Exemplars in Global Health work, and then we have the rest of the session focus on a panel discussion. How do we move from research findings to guiding interventions on the ground? So we'll dig into it. And the first two presentations are going to be delivered by Sumit Agrawal from the Indian Institute of Technology in New Delhi, followed by a presentation from Lourdes Martins from the Catholic University of Santos. Sumit, over to you. I just forgot to mention a very warm welcome to attendees joining us online. You're welcome to type your questions in the chat box. We have someone monitoring the questions coming through the chat. Sumit. One more housekeeping rule, apologies. We have an attendance sheet. We will be sending some more information after the session. My colleague Ksenia will be circulating it. If you would like to receive more information, feel free to sign up. Thank you. Sorry.
Yeah, thank you very much, Amel and everyone for giving me this opportunity. So I'll just talk briefly about some of the vaccine coverage mapping work that we've been doing as part of Grant Challenges India. And of course, this is in collaboration with a large number of other people, some of whom I've tried to name here. So our motivation, so we typically, when it comes to the local level, for example, districts within a large country like India, vaccination coverage data is available from sample surveys like the DHS surveys or NFHS as they are called in India. But we typically don't have very precise data on what fraction of children, for example, have got all the routine immunizations that they are supposed to get by the age of 5. So one complication in these surveys is that not everybody has sort of proper documentation of which vaccines they have received. So there's supposed to be a vaccination card where the date of vaccination is marked for each one. But in many parts of India, for example, the fraction of people who have that is not very large. And so another important source of data in these surveys is just the recall of the parents, in particular the mother who is typically being asked. So in many cases, the survey just records that somebody got a certain vaccine based on the mother's memory. So so there has been some work around, how reliable this maternal recall source of data is. How much does it add to the uncertainty in terms of estimating vaccination coverage? And so we try to use some fairly standard spatial modeling techniques to get some indication of how reliable maternal recall is. And, does it overall make coverage estimates more informative? Does it add more noise? So that's sort of the aim of the work I'm presenting here. So methodology, I'll just mention very quickly. So what we have is we have a bunch of sort of survey locations. So all over India, we would have a few thousand different locations, which are typically groups of 10 to 15 households, where they have gone and asked about all the children, a bunch of questions, including vaccination questions. And so what we use is a method called Gaussian process regression. I'll show you a quick example, but it essentially sort of interpolates between a finite set of points by doing some sort of weighted averaging, right? So we want to sort of be able to predict coverage at any location in the whole country, let's say, at a fairly fine resolution, but we only have data at a small number of locations. And one could also include other covariates, like socioeconomic or demographic factors, so age distributions and so on, which we've done a bit of, but you can get a fairly good idea even without that. So, sorry. Yeah, so I mean, this is just a quick sense of how it works. So of course, the real data we have is in 2 dimensions, latitude and longitude. But here, let's say you had just 1 dimension of space and you had all these purple points as being like the survey locations, right? So what the methodology is doing is it's effectively putting a probability distribution over all possible functions that could map from the location to the vaccine coverage, right? So the y-axis would be, let's say, the percentage of children who have been vaccinated. And so what it allows you to do is not only get a point estimate, like this yellow line, the purple line is saying what is my best guess at every location, but also the yellow shaded region is giving you a range of uncertainty that the model has, right? So this is a Bayesian method which is specialized to give you an interval rather than just a point estimate, and that's one of the benefits of this. So yeah, this is basically what we apply. And yeah, before I come to the actual results, just a very quick glimpse of some salient observations you can make from the data even without modeling, which is that so over the different survey rounds that have happened in India, overall we have seen an increasing trend in sort of full immunization, but there have remained major gaps within the country. So here, we have divided the set of states in India into 2 groups, one which we call the high performance states and one the low performance states. So you see that even as in the round that happened a few years ago, NFHS 4, the gap between low and high performance states was still fairly high, even though there was a major overall increasing trend. And again, some simple indications of what might be driving these differences includes things like maternal education has been found in many cases to make a significant difference. So within both sets of states, you see that the higher the level of maternal education, the more the coverage is. Wealth, as you might expect, and birth order is another one that was, I think, slightly surprising, that children who are born later, so the 3rd child or later, for example, considerably lower vaccination rates amongst those, and not a huge effect of rural and urban. So these were some preliminary observations. Okay, seems to be stuck. Okay, yeah, and this is just a quick map showing so at the district level in the whole of India, the full immunization rates. Again, this is as of 2015-16, which was the latest data we had at the time when we did this. So you can, of course, see there are quite a few districts where less than half of children are fully immunized. So there was a considerable gap, and in a way, the purpose is to more precisely map out where these gaps are and address this maternal recall kind of aspect of it. So yeah, so these are the kinds of results we get from that spatial modeling thing which I was describing, where if we look at sort of the upper picture, this is sort of the overall trend, and you can see this is a much higher resolution picture than, for example, I mean, this is just showing you one number per district, but this is actually on a grid of 1 kilometer across 1 kilometer, right? So this is showing you literally tens of thousands of points across the whole of India, where you have the overall coverage level. But what we also see is that the coverage based on this proper vaccination card is much lower in many parts of the country, right? So there are only a few regions which are like green on this, on the left-hand side map. And a lot of the data is actually coming from maternal recall. So as I said, the other thing these models can do is to allow you to get a sense of, yeah, I guess we'll have to be patient with this thing. Okay, yeah, sorry. So just to look at how the maternal recall and the card sort of relate to each other. I mean, this is a simple plot which shows all the districts divided into like the large regions or zones. And one thing you notice even from this visualization is that, for example, this red set of points, which is the northeastern part of India, somehow, has lower levels of mothers reporting children vaccinated relative to the trend line, right? So of course, there's a negative correlation because if large number of people have the vaccination card, you don't need maternal recall. But is there some kind of underreporting, going on in the Northeast in particular, which is a, relatively isolated region of the country? So we don't know, but this was, one of the things we found of interest, even independent of like the Bayesian modeling, which is coming up again once the slide shifts. Yeah, so now what we are showing here is, we had that sort of yellow band, right, showing how much uncertainty you have in the estimate at a given point. So this is sort of summarizing that uncertainty for data that comes from the card versus all the data where we also include the maternal recall. And so what it shows is that in most of the country, I mean, so basically the thing to note on this plot is just that there's overall less red here, right? So our primary question in some sense that does adding the data from maternal recall make your estimates more uncertain? The answer to that seems to be no. On the whole, the model fit is a little bit more confident after adding that data, which suggests that it's reasonably consistent, right? So if what was happening was that there were a lot of heterogeneities in that maternal recall data, right? A lot of fluctuations between neighboring regions and so on, then we would not see this, right? So this is a sort of good sign in terms of saying that the data might be reasonably reliable. And yeah, so here again, we are just showing as a percentage of the total coverage, how the uncertainty, so SD is standard deviation in that coverage, it sort of overall goes up, right? And yeah, this is just plotted another way. So I'm just, in interest of time, going to flick through these a bit quickly and come to a sort of summary of some of these things. So so we did observe when we look at other factors, like I showed you earlier on the slides, things like maternal education, that if you look at the availability of vaccination cards, it correlates quite strongly with development indicators, in particular things like maternal education. And so where you have high maternal education, you have a much larger proportion of children who are vaccinated as per the card, whereas for maternal recall, the trend sort of goes the other way. So in less developed regions, we are relying quite strongly on that kind of data. And then this uncertainty thing, which is what the modeling is really giving us as an extra. So again, the main thing, as I said, to note is that if you compare the red line, which is only using the vaccination card data, with the green line, which is combining the card and the maternal recall, it's much lower, right? So overall, your model is more confident in making predictions. So the data is not hurting. At the same time, if you just look at the green line, you find that in the regions which have lower levels of maternal education or higher levels of poverty, so basically places where there's less vaccination card availability, there is still more uncertainty, right? So it's certainly better if if everybody had a vaccination card. Some noise is probably being added by the maternal recall data, but not, on the whole, it's still helping, right? That's kind of a quick way to summarize these main results. Yeah, I mean, this was just to show a quick glimpse of, as part of this project, we are also setting up this kind of online dashboard, which is not complete yet, but hopefully we will be able to depict a lot of these results there to sort of make them available to people. Yeah, so I'll quickly just try to wind up. So we basically looked at the relationship of coverage and the uncertainty in coverage from this kind of spatial modeling with a few different covariates, and we found some, like maternal education, which correlate. And this is something that can be done at a more local level. Now, one other thing we are looking to try is, for example, having some way of modeling like different weightings for the card and the recall data to arrive at a more accurate estimate. for now, we've either completely left out the recall data or completely included it, but maybe you could weight it in some way to do something intermediate. And yeah, so we would also like to look at the recall data on its own to understand that better. Yeah, so I think I'm out of time, so I'll basically, these are just some summaries of things that we hope will come out of this in terms of informing policymakers about both drivers of coverage and reliability of coverage estimates. Yeah, thank you. So I think I'll end here.
Good afternoon. My name is Lourdes Martins. I am from Catholic University, and I will present this work. Sorry, because the buttons, the problem. Spatial analysis of vaccination coverage using secondary data in Brazil is part from this grant spatial analysis of children de 0 to 2 years. This study using the methodology secondary data in our platform. The secondary data used is administrative health data sets like live births, mortality information, the immunization system by the data source, and socioeconomic, demographic, environmental, and geographic data from IBGE. Sorry. And ISUS, data of ISUS primary healthcare by EXUS data. This all information compose a big data of secondary data. With this data, you use descriptive analysis, logistic regression models for identification the risk factors of low vaccine coverage, and spatial dynamics, distribution of vaccine by municipalities, and using the PNI stratification. Spatial analysis based on global and local moral index autocorrelation, like to identification where the low and high vaccine coverage clusters by municipalities in Brazil, and using the machine learning for the projection of the risks based on the low risk regression models of low vaccine coverage. This is part of Observatório das Vacinas, or Vaccine Observatory, that is a platform, a public website with open access data, and use the vaccine coverage doses applied by municipalities by year, divided by live births by municipalities and year for all municipalities from Brazil, and 11 vaccines from children 0 to 2 years old, and a 5 years data updated annually. The observatory is a research for policymakers because guide prioritization by public managers, easy access, and have information about how your municipality have vaccine coverage. Transparency, because all data is open access, public data, and not need specialized training for it. And feedback, the results is on the page of the platform of Vaccine Observatory, like that. When you go to the platform, you can put municipality, a vaccine, and a year. That I use Santos the example, I use Santos because Catholic University is in Santos. And then we can see the coverage. I present two examples with the data. Case 1 is a BMC Public Health. They study in the Northeast region of Brazil, in the Paraíba state, and for children 0 or 1 year old, all vaccine coverage. Then you can see the spatial distribution analysis. Then we can see where the municipality is low or high coverage. But this, in the spatial analysis, you can see that municipalities that use low coverage that influence negative your neighbors, and municipalities that had high coverage, high vaccine coverage that influence positive your neighbors. This is an important factor to policies makers. The case 2 is measles vaccine, spatial distribution, first and second dose in São Paulo city, state of São Paulo. The state of São Paulo had many numbers of municipalities. Then you can see the spatial analysis and the spatial, dynamic distribution, the spatial analysis. Then we can identify the low and high municipalities that influenced your neighbors. And the research from this work, this project, you constructed guides, tutorials, technical briefings, books and ebooks, and symposia of immunization in this year. We'll have 3 symposia. The platform developed a coverage indicator. This indicator, made by logistic regression machine learning, can identify by the municipalities the risk factors for flow coverage of all vaccines. And engagement with policymakers, we have ongoing feedback to the Ministry of Health, states and municipalities. We work together with the health ministry to identify the problems in the system and correct it. And the public health managers can evaluate with this indicator and this platform the risks of low coverage in your municipalities. This is part of a grandchild exploration Brazil data science. And this is a Observatório das Vacinas. If you can go, this is the QR code, and thank you.
Thank you very much, Lourdes and Sumit. If you can stay here for a couple of minutes, we have time for a couple of questions from the audience. Also welcome to take questions from coming through the chat.
Lourdes, those hotspots in Sao Paulo, those areas, you found hotspots. How did you respond?
The hotspots.
You can come here.
In the hotspots, we analyzed this, but it's more in the central region of São Paulo, of the state of São Paulo. Problems with economic and social affect these areas.
Did you go
Low.
back and immunize in that area?
Yes.
Mass immunization in that area?
Yes, we analyzed in the sequence of the work.
I think it was more about how did this information impact the action on the ground, the immunization on the ground?
This impacted because when we analyzed it and sent the managers the possibility to change the demographic, socioeconomic factors in your municipality, and with that, it's better the coverage. You understand? These indicators could be a manner to managers make a difference in your municipality. When you put in the model the socioeconomic, demographic of your municipality, then we projected how it will be the vaccine coverage with these indicators. You understand? So, by municipality.
Those hotspots get immunized. Do the areas of hotspots receive immunization response? Further
Do you want to?
immunization?
Yes, yes, big data, yes.
So I think they work very closely with the Ministry of Health in Brazil and different municipalities. And Alessandra from the Ministry of Health in Brazil is confirming that it is impacting. Yeah. Thanks for that question. Andrew?
Hi, Andrew Morris from Scotland, which currently is in the UK. But being serious, can I just congratulate you both? Two fantastic nationwide presentations. One thing we learned from the pandemic was that near real-time data is really, really helpful for implementation. So what prospect do you see of firstly, what's the periodicity of the collection? And secondly, what's the opportunity to get to as near real time as possible?
Sumiti? Oh, go ahead. You can come here.
Yeah, hope I'm audible. Yeah, thank you. So I think in India, we have actually been seeing real-time vaccination data for the COVID vaccination campaign. So there has been a sort of dashboard developed, which is tracking, numbers vaccinated at the district level. This did not exist for any of the previous vaccination campaigns. So the reason why we have to do this kind of modeling, as I was talking about, is that until COVID vaccination, there wasn't a very systematic way of tracking numbers. And while at the local level, there were some administrative reports that were supposed to count how many people are being vaccinated, but that data is very unreliable and noisy. So the only reliable source we had was these surveys, which are done every few years. But yeah, so now that system is there, I don't know if if there is thought on like using that for more regular vaccination campaigns. But at least for COVID, we do have that. And one of the things I wasn't able to show, but we have a sort of follow-up project we are just getting started on, where the hope is to partner with a social media company to sort of try and put out some messaging and interventions around promoting COVID vaccination in India, and to do a study to try and see if that kind of intervention affects vaccination outcomes or intent to vaccinate. So one of the sources of data for that will be this real-time kind of tracking of vaccination that is happening in India now. So yes, we do have that resource, at least for the current campaign, and it enables a lot more things which can be looked at.
In Brazil, besides the pandemic period, our data is available, actually available. Then we can actually actualize the observatory quickly,
Okay. Yeah.
because all data is available and actual.
I think we have time for one more question. Ula, it's going to be hard to pick one.
Should
Go
I
ahead.
go? I
Yeah,
got the
yeah.
microphone. Thank you.
You got the power.
Thank you so much for the great presentation. So both of the presentations focused on childhood vaccination. But for example, since COVID, now we are really trying also to reach the adult population. So I was just wondering how easy it would be to get this type of data also if we want to modeling adult vaccination at the moment. Thank you.
Anyone? You want to take a step? Yeah, go for it.
You use the population, the live births. It's not an estimate or a census population. You use the live births. Then the live births is actualized in the system quickly. Then we use this information to vaccine coverage. But in India,
Yeah,
Go ahead.
yeah, no, just quickly, I think so, as I was saying in response to the previous question as well. So now we do have a system which is kind of in real time tracking vaccination, at least for COVID. The hope is for any future adult vaccination campaigns also, we would be able to track that. And so, yeah, then there's a lot of stuff that can be done with that kind of data, which, we have looked into a little bit, but that wasn't the main focus of this project. Yeah, I think before COVID, I'm not aware of any like large scale vaccination campaign for adults that had happened in India. This is pretty much the first time it's happening. So I think systematic data that we had was only for the routine childhood vaccinations. But yes, now we have this system and this data, which a lot of people are trying to look at and better understand how you can fill in gaps in coverage for COVID, at least based on that data.
Yeah, thanks. I see we have Fernando Boza in the room, who did a lot of work as part of the ICODA-GC on COVID vaccine coverage in Brazil. And we'll just take a quick comment, and then we have to move to the next presenter.
We have worked with the national data from COVID-19, and we have dashboards and available with data and also different analysis using the COVID-19 cover in Brazil. Also other groups, the SIDAX groups also work with this kind of data. And you can find different dashboards and analysis of the COVID-19 coverage in Brazil at this moment.
This is a great segue to...
Yes, just a quick answer is that Brazilian data on COVID vaccinations updated daily. We had administered 500 million COVID doses. We did some comparative studies on vaccine effectiveness with Scotland people. And we do monthly reports on vaccine effectiveness. So those are available.
Thank you so much. Join me in giving another round of applause to the presenters. And this is a great segue. We'll hand it over to my colleague, Gloria Ichelezi, to talk about the Exemplars in Global Health COVID vaccine coverage.
Thanks, Emil. My name is Gloria Ichelezi. I'm on the Exemplars in Global Health team. Today, it's my honor to introduce our research partners. We have Dr. Steve Lim, who's a Senior Director of Science and Engineering at the Institute of Health Metrics and Evaluation based in Seattle. We also have Dr. Moussa Sarr, who is a Principal Investigator at the Institute for Health Research, Training and Surveillance in Senegal. Today, Steve and Moussa will be speaking about our exemplars in vaccine delivery research, and they'll highlight a couple of areas. One, they'll share more on our conceptual framework that we've used to guide our thinking and synthesis of our work. Steve will do a deep dive on our analytical approach. They'll also share the findings from both the qualitative and quantitative research and share some initial thinking on potential applications of this approach. And maybe just to share a little more on our vaccine delivery research, this spans 3 countries, Zambia, Nepal, and Senegal, but today we will focus on Senegal. So now I'll hand it over to you, Steve, to kick us off. Thank you.
Oh, I've got to... Great. Thanks, Gloria. As Gloria's covered, we use a conceptual framework summarized in this slide to guide both the quantitative and mixed method analysis that we'll cover today. The quantitative analysis is going to focus on the right-hand side of this figure. So in particular, looking at the relationship between the 3 main drivers, facility readiness, intent to vaccinate, and community access, and how they relate to coverage. And then Moussa is going to cover the upstream part of this framework with a particular focus on the past and present interventions to improve those drivers of vaccination. So I'll dive right into the first part of the presentation, if the slides will advance for me. Okay, the goal of this analysis is really to quantify the relationship between those three drivers and vaccination coverage. Now, to do this, we leverage all the existing secondary data to estimate spatial and temporal estimates of those three drivers. Really the objective of that is to leverage all the available secondary data. So we're not looking at doing new primary data collection. And that's an important objective of the work, so it can be replicated in a number of other settings. We then leverage machine learning approaches to analyze the resulting data set. And that allows us to tackle the main challenge of the analysis, which is the highly nonlinear relationship between those three drivers and vaccination coverage. Now, what I'll do is go into a little bit more detail on how we estimate three drivers of intent, access, and readiness. Starting with intent to vaccinate. So, of course, this captures the demand side of the equation. And we leverage surveys implemented by the Vaccine Confidence Project. And these ask caregivers about the level of agreement with three statements around vaccines. So, are vaccines effective? Are they safe? And are they important? And you can see the resulting regional variation in the fraction of caregivers that strongly agree to these statements, shown here on the right-hand side. You'll note the lower level of agreement, particularly in the eastern part of the country, so the more rural parts of Senegal in particular, but also lower levels of agreements in the more populous areas to the west around the capital city, Dakar. Now that's intent to vaccinate. For community access, what we do is to estimate travel time between households and immunization services, both fixed facility as well as outreach services. And here again, you'll note the much longer travel time that's experienced in those more rural parts of the country. Tambacounda, which is the first region in the figure on the right-hand side, is that southeastern region that I showed you on the map. And you'll note the much shorter travel times in Dakar and other areas in the west in particular. For facility readiness, we leverage, of course, the whole range of facility surveys that have been conducted. These include the service provision assessment surveys implemented by Macro. And we use these to characterize the various indicators according to WHO's service availability and readiness assessment indicators. These capture elements from staffing and guidelines to both cold chain and non-cold chain equipment, as well as service availability and, of course, vaccine stocks. You can see the variation across facilities in Senegal in the heat map on the right-hand side according to those various indicators of service availability and readiness. Now, what we end up with is essentially a geospatially located set of estimates for each of those three dimensions. So you can see community access on the left-hand side, depicting travel time to the closest facility, facility readiness in the middle panel, and then our measurements of intent to vaccinate on the right-hand side. We link each of those estimates to around 20,000 observations of individual children measured through the various household surveys, including the demographic and health surveys. What this results in, and this next slide, when it comes up, will show the results of that random forest model. This shows populations in Senegal ranging from the lowest quartile of community access on the left-hand side to the highest quartile of community access on the right-hand side. We focus first on the left-hand figure. You can see third dose DTP coverage represented on the y-axis, intent to vaccinate on the x-axis, ranging from highest to lowest, and then facility readiness ranging from lowest to highest on the z-axis. What's notable, of course, in that lowest community access group is the strong relationship between coverage and intent to vaccinate and facility readiness, such that amongst the population with the lowest intent and lowest readiness, we see coverage of around 75%. So that's the front corner of that figure. If we look at the population then with the highest intent and the highest readiness, so that's at the back of the figure, we see coverage levels that are approaching 90%. As we move across rightwards, so across increasing levels of community access, the relationship between intent to vaccinate and readiness and coverage diminishes, such that in our highest quartile of community access, coverage is universally high, so somewhere around 90 to 95%. So what this really highlights, of course, is the highly nonlinear relationship that we're seeing between these drivers and coverage, and the importance, of course, then of examining these drivers within the very specific context that we're looking at. Now, this analysis of the three drivers accounts for somewhere around 60% of the variation that we see amongst those 20,000 observations. So what we wanted to do was to look at how much of that residual variation is then related to other factors, or other demographic factors. And the results of that are shown here in the middle panel. You can see that in that residual variation, we still have a very strong relationship with maternal education, so higher education leading to a higher odds of being vaccinated. And then, of course, also household wealth, higher household wealth, higher odds of vaccination. But perhaps what's most interesting is the remaining regional variation that we see in the analysis, and that's represented in this map on the bottom right-hand side. And you'll note in particular those two southeastern regions, even accounting for the level of those three main drivers, intent, readiness, and access, still have a much lower odds of vaccination in those areas. So I think indicating other things that we would want to investigate in those regions in particular. Okay, so in summary, what our analytical framework and analysis provides us with is a way to understand that very nonlinear relationship between our drivers and the way that they interact with one another. Perhaps most importantly, though, it allows us for a basis for scenario building. So looking at what might be the impact of different actions to improve any one of those three drivers. And that's shown here on the right-hand side, showing the impact on estimated vaccine coverage of improving access from the lowest to the highest quartile, the same for intent, the same for readiness, and then the combined effect of improving all of those three drivers at the same time. That, of course, can inform all sorts of policy action around particular interventions to address those three drivers. Now, there are a whole range of other applications here. This is just one example for Senegal. We're in the process of doing this for other exemplar countries, but you can imagine the value of doing these, particularly in non-exemplar countries that have persistently low levels of vaccination coverage, as well as the potential for expanding this out to analyzing drivers of other health services. So that's the end of this section. I'm now going to pass to my colleague, Dr. Moussa Sarr, to cover the second part of our Exemplars in Global Health work.
Thank you, Steve. I'm doing wrong or right here. To the slide 16. Yes, this is it. Thank you. All right, thank you, Steve, for this first part of the presentation. I'm gonna give here some example of the approaches that has been used in Senegal to improve child vaccination. Some of those is a strong and successful community approach with the use of community healthcare workers, such as the Bajanogox. The Bajanogox, roughly, these are godmothers or community aunties that are trusted members of the communities. Not only work on vaccine, but all the other primary healthcare interventions. They help work with communities to provide education in relationship to vaccination, provide information on the benefits of vaccination, help dispel some of the mistrust and misinformation related to vaccines, but also help plan and coordinate the vaccination programs between the healthcare system and the communities to find the right time, to find the right place, and to find also the kids that are mostly in need for these vaccination programs. So as I mentioned earlier, instead of waiting for the kids to come to and their mother to come to the healthcare centers at specific time and specific places, the community health workers, including the Bajanogox, work with the healthcare system and the communities to find the are they going to the villages or the mosques, or basically the right place for this vaccination, identify the children that are mostly in need, and make sure that they are connected to the system, and also so basically just optimize the delivery of the vaccination programs to the community. These maps really shows the success of Senegal into improving this immunization coverage overall. If you look at the first map in UU 2000, most of the map was in red or brownish for low to very low coverage. But if you look at the maps, by the time that we get to 2019, most of the country is in blue or dark blue for high and very high coverage. Except just one of the districts of Kédougou, but most of the country is right now in blue or dark blue. This has been achieved thanks for a strong commitment of the Senegalese government for vaccination, but also a good coordination and communication between the healthcare system from the central level, district, peripheral level, so top down, but also bottom up. The issue that I discussed at the peripheral level also goes all the way up to the central level, and I'll take it into account. Working with the community and community health workers, we have mentioned that earlier. But very important also is a data-driven approach. For example, the type of work that we're doing here, quantitative work, in combination with program data. All of these are used for decision making, and make sure that, for example, the areas that are mostly in need receive the support that is needed. This is done in a context where there's still some challenges in some regions, such as the Kédougou or the Matam region. Have some challenges in the beliefs on vaccine safety or vaccine effectiveness. We can see these within some communities, such as the Fulanis. But these challenges are not absolute. For example, if you look at in the map on the top, the Kédougou region has the Matam region has significantly improved its vaccination coverage by 2019, despite these challenges. That means that still with the strong work with the community, using trusted members of the community, some of these challenges can still be elevated. But the Kedugu region has still some additional challenges. It's a region where I believe it's the only region in Senegal that has mountains, so access is a major issue. There's also some mining activities that are predominant in the Kedugu region, with a lot of mobility in these populations going back and forth to Guinea or Mali. So basically, and there's even some discussions of working with districts of the neighboring countries that usually have lower vaccination coverage. So when the kids go back and forth from these regions to the neighboring countries and back, this also affects vaccination coverage. So just to say that these challenges are not absolute. And the same way that they were successfully, that we overcome those challenges successfully in the Matam region. I mean, even in the Kedugu region, beside one of the districts, it's that we are also going toward the direction of having a blue in all the region. But hopefully, the next year or two, when we come back for these new maps for 2021 or 2022, we're going to have all the country in blue and dark blue. All right, thank you.
Thanks, Dr Moussa. We welcome questions from you all. A couple of questions.
Oh, here, close this. Thank you so much. That was incredibly educational, but also, I think, remarkable in terms of success. My question is around the cost of doing this. Obviously, Senegal is an exemplar. You've done wonderful things. You've engaged the community health workers, which I think most other countries have not done as effectively. And I'm just curious, is this a cost-effective model that could be and should be, sort of used throughout Africa, or is it really an exemplar which is very well funded, that is not something that could easily be replicated without tons of money? Thank you.
Yes, I mean, there's a strong coordination between, I think that also between the Senegalese government and programs such as Gavi, UNICEF, WHO, but also the involvement of the Senegalese government. There's also some local funding at the healthcare center level that also goes into vaccination. Definitely some cost work will be also helpful to look at, for example, the cost of vaccinating one child. These costs may probably be different if you vaccinate a child in Dakar, where the proximity between the healthcare workers and the healthcare centers and the community is very, very close, versus a region such as Tambacounda or Kedugu, where the distance between the healthcare centers and the healthcare providers and different villages can be very large. And this can also not only inform costing overall, but also inform the planning at the Senegalese government level for vaccinating one child. But definitely the costing is something also important to take into account for if you want to use the same drivers in different countries. Thank you.
Steve, do you want to jump in as well? Or do you... Okay. All right, we'll take the next question. Thanks, Moussa.
Thanks to both speakers for the excellent talks. The question I have is also an operational one. When we have maps that are so detailed, we know it often requires powerful computers to be hosting or a good internet connection and so on. What challenges did you experience in getting these kinds of outputs to a subnational level, to the community workers and so on, in order to be able to generate day-to-day or short-term decision-making on vaccine initiatives I'm basically wondering about the challenges operationally. Sometimes it takes very long to integrate, these outputs into a government system, a government IT system. It can take months to do such a thing. And sometimes governments are not always open to hosting information like this on a private platform. So I'm just wondering, it's a general idea on some of the challenges that you might have experienced. Thanks.
Yeah, I mean, overall, we can say that the data system and the IT internet is pretty good in Senegal, up to the peripheral level. There's an organization, it's like the Senegalese government IT department that also works with all the healthcare centers. That allows also the reporting of the data, such as the IRESSEF data, all the way up to the national level. So overall, I can say that roughly it's a good system that's working in country. Sometimes there's also the work of offline systems where during times when there's challenges for internet, the healthcare workers can still, upload information, and then whenever there's availability of internet, then the data is uploaded to the central level.
Thank you. Yeah.
Thanks for the presentation. My question is related to integrated services. And I know in some contexts, colleagues have been struggling to identify the limits of how integrated can services be. If you could give us an idea about what you managed to include in this package, and whether it had things outside of direct immunization, like wash services or things of the sort. Thanks.
Yes, mostly, for example, for the outreach programs, when it's happened, it's pretty broad. It's more like a primary healthcare approach where, yes, vaccination is included, but for example, maternal and child health programs, antenatal care, most of those are also included. So that when the mothers come, not only they can get a chance to receive support for, if antenatal care is needed or other items related to maternal and child care, but also the child that they have can also receive the immunization right there during this outreach program. So definitely, most of the activities related to primary health care, the basic primary care, are integrated into these approaches.
I think there's a question at the back, and then we'll come to you.
Thanks. Thanks again. Excellent presentation. So my question is really whether you've also linked this data with other indicators like neonatal mortality. I was quite struck by looking at the vaccination coverage from 2000 to 2009, how that's changed. If you map that with neonatal mortality, what are you seeing? What can you actually say has been the impact of the increased vaccine coverage on something like neonatal mortality, which is a hard indicator? I don't know if you had opportunity to link.
Yes, and I think that I was usually giving one of the anecdotes that I've kind of forgot to provide in this presentation, is that in the year 2000s, for example, the mortality related to measles was really high in Senegal. There was a ward completely dedicated to complicated cases of measles in the infectious disease department in FAN. Not only that ward has disappeared, but most medical students right now don't even get a chance to, luckily, don't even get a chance to see measles cases anymore, during their training. So definitely there's a strong link between neonatal mortality and this success for vaccination.
Steve, would you like to jump in on that as well?
I'll jump in.
Steve, you're going to talk about linkages to NMR?
Well, the question I was going to ask, actually, yeah. Steve, my favorite plot of yours is the most boring one you have up there, which is that flat 3D surface. I'd love, my interpretation of that, it says basically that if I have proximity to vaccine, if I have access and I'm not physically impeded, intentionality is irrelevant to the degree you modeled it, right? So right. I'm just curious if that's an overstatement, because I think that's a huge opportunity for people to think about. If, people who are reluctant to get vaccinated, that reluctance didn't impact if the vaccine was available and close by.
Yeah, I think, I suspected someone was going to ask that question. I like to think about it more on the left-hand plot, right, which is in the areas that we really care about, intent and readiness really matter, right? But on the right-hand plot, I agree. I think proximity is a big issue. And I think the other thing we have to remember is that, the intent and readiness measures are really cross-sectional, right? So it's readiness on the day that someone went to the facility to collect all the data. But because those facilities are close, there's an opportunity to go back there multiple times, right? So there's some nuance, I think, to that statement that readiness and intent don't matter. And it's complicated, I think, by the kind of cross-sectional nature of data collection. And then, but certainly proximity matters.
Yes, and if I can add, the closeness between the healthcare workers and the community is also very important. Having a trusted member of the healthcare system that is able to talk directly to these communities is definitely something that has shown to be successful. For example, if you in the data that Steve has shown in some of the regions where distance between those two is long, mostly in Tambacounda and Kedugu, there's more challenges to overcome those challenges in those regions. But so definitely this is something that's very important.
Yeah, Himanshu here. So just as a follow-up, so did you see any correlation between family income and the distance? Because many a time in India, what we see is that for poorer families, access is usually farther than for the richer family. I'm talking about rural areas, and I assume that the district you're talking about is more rural than the other parts of the country. So is there because in India, if a person or a mother or a father has to go to a clinic, that's almost a day's wage gone. And does that come into picture in terms of the decision to vaccinate or not?
No,
for a family.
Yeah, there's certainly a relationship between household wealth and then distance to a facility. I'll also note that what we did do as part of characterizing that community access is to take into account vehicle ownership, right, as a mode of transportation to the facility. So that also factors explicitly into our measure of community access. And then as I noted in the analysis, we still see this residual effect of household wealth also on the likelihood a child is vaccinated. So that's on top of that relationship that's already baked into community access.
There's a question at the front. Go for it.
Yes, to Moussa, this is Agnes from APHRC. My question is around, you mentioned your robust data collection system. And have you encountered any challenges around record linkages, particularly in populations that might be very migrant? And how does this fit into the estimates of vaccine coverage?
Yes, there's definitely in some of the regions that are mostly in the border area, mobility is a major issue. We have some of the kids and their family that migrate based on for example in the area of Kodugu where we have a large community of mining communities that moves in and out of Senegal and Guinea and Mali. So the main challenge is when they're out of the country, we don't have information on their vaccination status, and even the neighboring countries have until now at least more challenges for having a higher vaccination coverage, such as in Senegal. So that's the main challenge that we have. But mostly when they come back in country, the system is pretty much works as well. If you are in Dakar or if we are in Kedugu, whether you are in district level. So pretty much the system works pretty fluidly between.
There's a hand at the back.
Hi, great presentation. I only caught part of it. And if this question is redundant, just tell me you talk to me offline. However, I want to follow up on Steve's question. And I'm looking at what components of your research is actually translatable into actionable input. One of the challenges we have with data science is this challenge of correlation. And the data scientist will tell you that the data indicates that it's statistically significant or it is relevant, which is part of the answer to Steve's question. But part of our challenge in the field, especially with policymakers, is what components of your output is actually translatable into policy and actions. So from your presentation today, can you extrapolate what those are so that we can learn from it? Thank you.
Thanks for the question. So, I like to think about what we've done here as a step towards that, right? So we've gone from trying to understand where unvaccinated children are, right, which is just that purely descriptive analysis, to then trying to step into a causal inference world. Now, of course, that causal inference world is complicated by the fact we have observational data, right? It's not a randomized trial, so it's not really truly causal inference. But it really is a step in that right direction to try to understand why children are unvaccinated. Now, the question about how well that represents a causal relationship, I think the only way to probably do that is to then make those actions, reevaluate the analysis. Do you see a concordance then between that resulting analysis and the subsequent actions? But yeah, I think causal inference is, as you're highlighting, right, a minefield of, whether or not that what we're capturing is actually a real relationship.
Yes, and then if I can add to it, usually the data is used in combination with other information. So this data, the great work that Steve is doing is very helpful to the Ministry of Health. This is also used in combination with qualitative data that we receive, programmatic data, and all of these are discussed to see how this can help drive, keeping not only the vaccination coverage as high it is now, but also, address some of the issues that we see, for example, in the only district right now that is left not blue, to discuss with those community and all this health system, talk about them to see how we can address and hopefully have the entire country in blue. But it definitely is a combination of work
Just a comment here. We analyzed data from Brazil for COVID-19 vaccination coverage in the whole country, and one of the major drivers to have a high coverage, especially in poor communities, is really to have a good primary care covered in that community. I think that this is a major message that we need to really think about, that vaccination coverage, it's not just the vaccine, but is health system trust and facility to especially poor communities to have access to this important to control different diseases.
Thanks. Very much agree with that statement.
Yeah, and that's what we have been discussing so far, Steve.
My name is. Hello?
Yeah.
Hello, my name is Cindy from APHLC. Looking at the way the progress of the work in Senegal, it seems we were able to move from brown and whatever to blue very easily in many of the part except a small area. What is so special about Senegal health system which other countries can learn, and in particular some of the countries which have a migratory type of population like cattle hunters and all that, and I am handling although whether Senegal has that type of a population in the Sahel. And the question is, you say that the system is able to capture even when they move from one country, they come back to Senegal. It's possible for you to get that. What is that special? What is that? What makes it tick that it's possible to do that? Because if we understand that, maybe we can also work in other countries that build prototypes of that type of a system which can work. Thank you.
Yeah, thank you. I mean, most of the work that we're doing in the Exemplars program is really basically just that approach of finding the drivers of for a successful vaccination program in this country and see how we can share that information and see, and everybody will see how these can be adapted or not adapted to other countries. In fact, but for Senegal, for the mobile population, in fact, what I said is we kind of lose information when they're out of the country. So we cannot capture the information when they're out of Senegal. So right now there's work to see how we can work with the ministries of health on the neighboring countries, at least with the districts that are right close to the border, so that we can have some kind of link or coordination of activities, so that we can not only capture the information when they're out of the country, but also at least keep the vaccination coverage high among those kids who are, with mobile families.
But I was asking, what about the health system, which has made things move from brown to blue in most of the other part of the district? What changed? What is so special about the health system in Senegal?
Yes, I mean, I've mentioned few drivers. First of all, there's a strong commitment of the Senegalese government overall at the top level, for vaccination. There's also a strong coordination between the central level, the district level, and even the peripheral level. So they have these peripheral level, district level committees that discuss issues related to vaccination, challenges, and so forth. And those issues goes back all the way back to the central level. So it's not only top down, but it's also bottom up. There's a involvement we have mentioned about the community and community health care workers, but also grassroots organizations, the media, or that are also involved into these activities. And the data-driven.
No, I was just going to jump in and say we're happy to share a set of findings mapped to the different.
Yes, we have some more details and even papers that are coming out that highlights or much more in detail the work that we are doing and the drivers of the successful immunization program in Senegal. We'll definitely be happy to share those.
Okay, thank you so much, Moussa and Steve, and thank you all for such a great discussion.
Great, so we're going to move to the panel discussion next. So I'll ask our panelists to come up. I know it's a packed room, so it's going to take a bit of shuffling. And I would just say thanks to the audience as well for such an engaging discussion and questions. We will be sharing a link to a survey after via QR code after this. So if you have further questions or contributions you want to make to the discussion, I think we'd very much welcome that going forward. So let's see. I think we have, Barry, Akin, Alessandro. Let's get everybody up here. And yeah, great, thank you. And maybe while everybody's getting settled, yes, I'll hold on. Hopefully. While everyone's getting settled, I think I had a couple of reflections coming out of those presentations that I think will carry us nicely into the next session. I think from my perspective, seeing that kind of granular spatial mapping of vaccine coverage, the platforms to ensure access to that data, and then really kind of that goal to support real-time decision-making is really interesting. And then complemented by this exemplars view where, yes, we're looking at a national level. Yes, we're looking at what's worked well in the past, but really, I mean, as per the conversation that we just had now, there's a lot of application to other countries and within the country itself. Looking at Senegal, there's areas for improvement. We want to continue that support and that dialogue on the use of that data. So with that, Steve, do you have any additional comments you'd like to add?
I think we'll, at this point, get into the discussion with the panelists because they're all going to represent a perspective of how data, as you just saw in the first half of the presentation, would be brought into thinking on impact on policy to the point, the question that Uwe had asked earlier, how do we take this and actually go to impact? So we're going to start off first with Alessandra, who's here from Brazil, and maybe a brief introduction of yourself, and then I know we have a couple of slides, I think, of yours.
Yeah. Hi, everybody. It's a great pleasure to be here. I'm Alessandra Siqueira. I'm the Director of Science and Technology in the Ministry of Health in Brazil. And I'm a PhD in clinical medical, and I'm also a cardiologist. So what's not written in my lattice is that I'm a mother of 3, and that's why I have a conflict of interest that I really want to change people's health conditions. Well, it's a great pleasure to be here with you. First, to discuss how can we build the bridge between research results and intervention on the ground. The first question that I made for us to think is it really possible for us to make science accessible for policymakers? And we have to think not only for policymakers, I know we're talking about that in this panel, but how about for everyone? Saying that, I'm going to show you how big my problem is in Brazil. I know we have here in this audience a lot of people from Brazil, really good scientists that help us all the time in the Ministry of Health to change that perspectives. And I'm going to show you how big is our problem. It's 250 million people, one of the biggest public health systems in the world. We are talking about one of the biggest, largest database in health. Can you change the slide?
Yes.
So what we do have that is different from other countries is that we have a national immunization program that is the greatest achievement of our unified health system switch. Since 1973, we have delivered free vaccines to all the people that live in Brazil. That makes us a difference in our vaccination program in COVID vaccinations, because we could reach 74% in Brazilian populations already. It's 488 million doses already given. And that was only possible because besides all the investments that we do in research and science in Brazil, we monitor the data in real time. That's the only way we can do that. Seeing the scenario and changing in local areas, the panel that we are having. And the reason that I think I'm standing here is because Brazil has been a global reference in vaccination since the day I was born. But please don't do the math. This could be a little secret, right? I already told you I had 2 children, so. And we were used to have those great numbers. But can you change the slide? Yes. Our scenario has changed. Now, Brazil has lost our certification as measles-free country in the past 2 years. Poliomyelitis has been a trouble that we have to deal with nowadays. And our numbers in the children's vaccinated now is above 50%. And when we are facing these numbers, what the main reason, I think, is misinformation. We are talking this morning about that in the big panel, and the problem is that we are going to have the reappearance of pathogens that weren't circulating in Brazil anymore. And that's not a problem for only Brazil. That's a problem for all of us. And so I wonder, what are we missing? What can we do to change that? Can we change this? We need to improve communication skills, translation, scientific efficiently to all the stakeholders. And that includes the general population. I'm not talking, this is a problem that we live in Brazil. It's a problem for all of us. And to sell this issue, we have to do it together. I'm showing the slides of my department, is the CIT, Department of Science and Technology. And I'm proud to say that in 22 years of history of our department, we already invest in 7,000 scientific research studies. Since the beginning of the Evidence Informed Policy Global Network, we've been leading this discussion in Brazil. And during the pandemic, we started to produce the evidence synthesis. We already produced over 350 scientific evidence to change our decisions. We keep looking for solutions. Now we are developing an in-house project so that we could use more data and scientific knowledge, so we could have that in real time in our department and in the Ministry of Health. We are committed to develop research priority agenda, and this is our future challenge. I'm going to finish just a little bit. I'm going to finish telling you just a little phrases for us to think. I know we all are doing a lot in research. I doubt to say that the problem is already been solved. Yesterday, we were thinking about truth in science. I cannot believe that people don't believe in science anymore. And I think all my colleagues here will agree with me that if this is not a Brazil problem, it's a global challenge. Science has to be reliable again. Science has to be for all. I'm always talking about dreams and my fears. I don't fear the uncertainty of science. What I fear the most is not changes people's health condition, not only in Brazil, but all around the world. Thank you.
Thank you, Alessandra. So we're going to move next to Abere Okereke, who's a senior technical advisor with the Tony Blair Institute. Abere, over to you.
Thank you very much. And good afternoon, everyone. And it's been a really interesting session listening to the research so far. So for some context, I'm a public health physician. I, until recently, worked for what is still the UK, Public Health Security Agency. It used to be Public Health England, at least last time I checked the news. I don't know if anything else has happened. I'm also have the privilege of being an honorary advisor to the Director of Africa CDC. In the Tony Blair Institute, one of the approach we take is to help governments to deliver. Most governments are elected, or however they get into government, they have a commitment to the people who keep them there to deliver on key priorities. And we work at the center of government to help them to deliver those priorities. Unfortunately, in a lot of African countries where most of our work is, although we work in other regions as well, health until recently hasn't often been a priority. And therefore, the center of government hasn't given it the attention that it requires. One thing I'm calling the COVID pandemic dividend at the moment is that concentration of attention on health and the recognition that you do need those health programs for your economic development and everything else you want to achieve. And as a consequence of that, we are now working with a lot of governments who are trying to understand how they can leverage some of the investment in terms of new data information systems and expansion in workforce to translate the learning from the COVID vaccination, COVID pandemic response in general, and specifically on the vaccination to strengthen their existing immunization programs. I was sort of, your figures from Brazil were probably more drastic than, we have more drastic differences, but in the 80s and 90s, and I won't say which decade I was in medical school at, we had in Nigeria, where I'm from, far higher immunization coverage rates than we have today globally, childhood immunization programs. And what happened over then was actually a loss of attention on immunization at center of government. And so in addition to answering the question as to what are those factors that change, that contribute to successful or less successful immunization coverage, be it adult or childhood or adult, or even in a pandemic response, I think one of the things that we need to understand to complement some of the factors that have been highlighted in presentations today is the economic factor, the political factors, political small p, at all the levels, from national to subnational. What are the political determinants of an interest in seeing vaccination coverage optimized? I think those are some key questions that we need to understand better so that we can understand what you then need to change to make sure that those other factors around having an effective health system happen and are utilized to optimize our immunization coverage, both for children and everyone else that we would want to vaccinate. I think it's particularly important that we understand it now as the new technology, mRNA technology and everything else, presents opportunities for new vaccines that may be targeted at across the life course, not just as children. So again, I would agree with, there was a comment from the center about the primacy of having a health system that people can reach, a health system that people trust. But you also then need to understand where decisions are made, who makes those decisions, and what are the factors that influence the decision they make. And for that, we do need to start to understand who are those political decision makers, how do we inform them, how do we understand what they need in terms of information and provide that information in an accessible manner so that they can actually make the decisions that lead to improvements in immunization coverage, whether it's existing childhood immunization programs, introducing existing new vaccines, and expanding to start to look at vaccination across the life course. And I'll just pause there.
Thank you.
Thank you very much. And next we'll have a reflection from Professor Akin Abayomi, who is the State of Lagos Health Commissioner in Nigeria. And maybe you can also follow on some of the comments from Barry.
Yes, thank you very much. I guess as the Commissioner for Health, I would be regarded as a policymaker, and therefore I'm in the hot seat. So yes, obviously we rely on information from the academic environment and from the donor agencies, as well as our National Primary Healthcare Development Agency, which is predominantly responsible for giving us this data. But that data is not entirely satisfactory because one thing we learned from the COVID outbreak was, by digitalizing access to the vaccine, it gave us real-time information, which helped us to craft a vaccination strategy during the pandemic. And aside from that, our routine vaccine data is more manual, it's more unreliable. And across the country in general, Nigeria is 200 million people, like Brazil a little bit, and the centers where you get these vaccines can be anything from accessible to totally inaccessible, or well-built and designed, which is a rarity, to, huts or repurposed facilities that are totally unsatisfactory, difficult to reach, and, manpower is short. So as a policymaker, what have we decided to do in Lagos State? And I can only speak predominantly for Lagos State, is we've assessed a lot of things. Now, let me start by talking about a group of healthcare professionals that most people don't pay attention to. And those are what we call the traditional medicine practitioners. And we call them the TCAMs. I don't know what they're called in most parts of the world. So the traditional, complementary, and alternative medicines. And in Africa, most people will visit a traditional practitioner before they come to an orthodox practitioner. And so we're usually deceiving ourselves when we think that we're the first port of call, even if it's primary healthcare. Prior to primary healthcare, there is this layer that is massive, and it is not subject to brain drain either, because they're part of the community, and they're not able to present their credentials internationally because they're not recognized. So we're working very hard on this group because there are a lot of them, and they do offer a huge amount of healthcare advice to the community. And so we've set up a regulatory framework, a board made up of members, practicing members of this CADA. And what we're trying to do is pull them into the system so that we can regulate them and we can teach them what are the boundaries of their competencies, and also give them information that they can disseminate into the community. And then, through an awareness program, the community can come into the primary healthcare and receive their vaccines. So that's at that level. At the primary healthcare level, we have in Lagos over 300 primary healthcare facilities to service 30 million people. Now, that is just not enough. And even of that 300, about 2/3 are not in a satisfactory state. So what we've done is to develop a blueprint. Most of these facilities are repurposed houses or repurposed schools, or just not built fit for purpose. So we've developed a blueprint of primary healthcare facilities, 3 prototypes, a comprehensive, which is almost like a mini healthcare center, then a primary healthcare center, and then a healthcare post. And they all have increasing levels of complexity in terms of what they can do and what personnel are available at these centers. And so we're just beginning to roll out these blueprints. What is the blueprint? The emphasis on the blueprint is designed by architects who understand primary healthcare dimensions. So what is the patient flow? What is the staff flow? And for us, with climate change and with the fuel crisis, the cost of ventilating these facilities is becoming above the sustainability of these facilities. So these are low carbon footprint facilities. They have this outside indoor waiting area concept. They're cool, they're very easy to manage, and there's a lot of attention to infection prevention control. So we're going to roll these out and replace these defunct facilities, improve the environment for the community to be attracted to these facilities to receive the benefits of the EPI schedule. The other thing we're going to do with aggression is what's called the SHIP, which is a Smart Health Information Platform. And we picked this up from COVID because we realized how useful it is to digitalize because of the real-time data you get. And the SHIP is basically, we're laying fiber optic cables all over the state, high-speed fiber optics, and we hope to link up all our health facilities, starting with the primary healthcare level. And so that when patients are coming in, we're not reliant on manual data, and we can get real-time immunization data, which helps us to define our policies. Now, Lagos is the commercial capital of Nigeria. And because of certain things going on in the country, breakdown of security, climate change, desertification, we're getting a lot of inbound migration. And so in Lagos, we receive about 3,000 people a day coming into the city, and nobody's leaving. So our populations are rising, not from fertility, but just from inbound migration. And where do these people go? They all go into increasing and exponentially increasing numbers of slums, which are much harder to monitor, much harder to find out what's going on in there. And these become hotspots for the circulation of not only pandemic diseases, but things like the polio, the vaccine-derived polio and things like that. So a lot of attention to slum health, digitalization, correct infrastructure, and paying attention to the level below the primary healthcare structure, which are the traditional practitioners. I think I'll stop there.
Great. Thank you so much, Akin.
Amy, can I just make a comment again,
go
which Akin's experience and what he's just described and how it links back to center of government. In Nigeria, Lagos State is probably the most efficient state in terms of tax collection. And therefore, you have a government that actually has the funds to respond, to address priorities like health, and is able to then center health as a priority for delivering recognition that, as we were discussing earlier, Lagos responded much more effectively to the COVID pandemic in recognition of the economic impact of not responding. And again, it comes to that necessity for us to move away from seeing health as the Minister of Health problem to putting it back in the center of government and seeing it as fundamental to everything else that government wants to achieve. Sorry, I get off my heart. That's my soapbox.
That's exactly the discussion we like to encourage here. So our fourth and final panelist is Taya Norman, a senior program officer at the foundation. Taya, feel free to let me know how you want to advance slides.
Please go to the next slide. And it's great to be here with these other panelists. And I'll just share a perspective from I'm at the foundation, so I'm the funder perspective, the donor that you mentioned. And so at the foundation, I lead a team that stood up over COVID called DAC, which stands for Design, Analyze, Communicate. And this is a team that's really thinking about the responsibility of funders to make sure that the clinical trial work that gets funded by the foundation, including implementation of research studies, is optimized for an informative outcome. And by that, we made some outcome to the research question that allows somebody to do something next. And so policymakers are a target audience for us when we think about this. And so our work is really focused on supporting grantees at the Gates Foundation when they're planning at the early stages of thinking about what is the study, what's the research question. And so our acronym, Design, Analyze, Communicate, is to prioritize these different areas of planning that are so crucial for an informative outcome and the impact that we see on this slide. So if you can go to the next slide. So already on the panel, you've heard about communication and how challenging that is. That's the C in DAC. And when we think about improved health outcomes and how do you map all of the amazing data we saw today and the stories we heard about local impact, how do you make sure that data is organized in a way to help policymakers make decisions? And when we took a step back within the foundation, what we see is the current state is that there's really no formal consistent method for global health stakeholders to get input on policies. And so one of the tools that we have stood up and been piloting is called the Target Policy Profile Tool. We call that the TPOP. If you go to the next slide. And so this is anybody in the audience who has heard of the Target Product Profile. This is a tool that's been used by the pharmaceutical industry for a number of decades now and really helps organize at the early stages of planning. What's the indication going to be? What's the label going to say? And it helps everybody steer in the same direction and to get to that goal. And so thinking about that as the inspiration, the Target Policy Profile is similar. And really the benefits are that it helps identify what the barriers are to getting to a new policy. It shows what evidence is needed. So as a funder, I want to know what evidence should the Gates Foundation be funding? What new clinical trials need to be done so that if the evidence comes out, a policy change can happen? And so from a funder perspective, that's what interests me. But for everybody, I think this is a tool that all stakeholders can think about and factor into their work. And so really, it's quite simple. What is it? It's a table. There it is on the slide. And we have it available for download in 5 different languages. So it can be used by all of you. We've seen a number of use cases already over the last couple of years in terms of who fills it out. The WHO can fill it out. A country-based Ministry of Health can fill it out. A consortium like the Single Dose HPV Consortium can fill it out to help inform policymakers about the evidence and the different stakeholder perspectives that all need to be lined up so that a policy change can happen. So next slide. And so when to do one, what we've heard from our country-based partners, ministries of health, is the earlier the better, and this goes to money and politics and budgets. And so making sure that governments are going to be behind and supporting policy change, giving them line of sight to what the vision is, and aligning with them early is key. And so we would say doing it early is good, and it's a living document. So as you move forward in your program, you can update it and realign and make sure everybody stays on track. And this is resonating because there has been a gap. It is hard to get all of the stakeholders around what we call the kitchen table of the target policy profile to have that discussion all together to make sure that, okay, when we go and we have that important meeting with policymakers, we've got all the different perspectives represented and we're all aligned. Next slide. So just to say, I hope these slides will be available for you. I'm just going to say there's already some nice examples of different stakeholders using it. So this example here, where there's a paper you can read about, is thinking about ministries of health and how countries can use this to help implement their own policies and to accelerate the time process that it takes to move those forward. And then I think the last slide is just to say that the WHO has also been piloting this concept in the TB vaccine space. And so they've been really a leading force here for creating a template that can support within the vaccines division at the WHO. And the first example that they've moved forward with a really extensive working group is focused on TB vaccines. So I think that might be my last slide.
We'll double check, but.
So thanks for listening and happy to answer any questions about this approach from the foundation.
Great. Great. Thank you for our panelists. So I know Steve and I have a couple questions, but we will save time to open up to the floor for some questions before we run out of time. Steve, do you want to go first?
Yeah. Actually, thanks. And Akin, I really appreciated your comment about reaching out to the TCAM providers who I think too often in our science-based health, we tend to write off as, those people, right? And but to the point that Moussa made about trusted community health worker, it's a trusted individual. So I'm curious about, how that program is moving forward and integrating with more of the conventional healthcare. And then Alessandra, maybe following Akin, just how the public health system in Brazil actually is so embedded in the community that it is actually that trusted force. And is that a part where, a place where you see a lot of variability, and does it relate to perhaps some of the places where vaccination rates, for instance, are better or worse? So Akin,
Yeah, so ultimately the idea is to reduce quackery at that level. And you do that by training and accreditation and regulation and surveillance and monitoring. So essentially you want to eliminate the people that are moving expired drugs or hawking concoctions around on the street. And these concoctions haven't been tested or tried. They can be toxic to the liver and kidneys and all kinds of things. So you want to eliminate the quackery. Then what's left, you want to educate them and to show them what are the limits of their boundaries of practice, so that they don't overstep their lane, and understand when they need to disseminate information, whether it's about vaccines or it's about HIV or it's about COVID. Practice within their lane and then learn how to refer appropriately. So if, for example, a traditional birth attendant is seeing a pregnant woman, the important thing is that the first thing is to ensure that she's getting antenatal checks, and you're defining whether this is a high-risk pregnancy or not. And then if it's going to be a straightforward delivery, then she can take, or the TBA can take it in community, but recognize when things are going wrong, or preferably if it's a high-risk pregnancy, to refer it to one of our multiple general hospitals. So it's important to use this group of professionals in the context of vaccination. As they are part of the community, they can be very effective in disseminating information around the schedules of EPI, and that these vaccination programs are extremely beneficial to the kids and to the family, and encourage them to go to the primary healthcare centers to get their schedules?
Yeah, it's a really good question, because we were talking about trust of science, and actually we cannot have people believing in us if we don't have the population to have access to the vaccination. So this is the first step that we have to do, is to deliver wherever they are the vaccine, so that they can go there and apply in their arms. So that's what we do that is really different from other countries. So we have some programs in different regions that are really far from the capital. So we can do vaccination boats. We can do vaccinations getting into the population. So that's about the delivery. So that's how we solve our problem, because we have Indians and all of that around country. And we have some regions that we have really bad access to hospitals. So our primary care is one of our great investments. So that's why our program immunization is a success. And what I have to tell you is that since our department is in Ministry of Health, it's easier for us to produce the evidence and also be there and show the numbers, because the program is all the time looking at the numbers to see if there is another disease going on. We had a success in monkeypox, for example. So the first case that was in Brazil, we were already asked for, I don't know, 30 synthesis of rapid response. So we could say what the science was going on and what we could do about it. So I think that's the part of the success.
Great. Thank you, Akin and Alessandra. So I think we've heard you're each working with ministries of health from within and as advisors and sort of almost TA providers with these tools. I'd be really interested to hear from you on what you see as some of the challenges to support that evidence-based policymaking. And I want to link it as well with some of the themes that have come out of the conversation today. I think we've heard a lot about innovations coming from COVID-19 response, thinking ahead, not just to COVID-19, but future immunizations and particularly adult population campaigns. What are the kind of top 1 to 2 research priorities that, or evidence needs that you see kind of looking forwards to support those Ministry of Health decision makers? Big questions. And maybe to even it out, I'll start with a Barry, and then we can work our way through.
Thank you. I'm going to pick an easy one. Someone else can take the difficult ones. Information. We've talked a lot, and the whole of the first half of the session was around data and analyzing it and interpreting it and getting it. But data is only data unless you can put it in a format that is actually useful. And we as scientists and public health practitioners are used to looking at those lovely maps and understanding what they mean. Having had the privilege of working in centre of government, both in the UK and in a lot of African countries, that data presentation is no value. So what we are not very good at scientifically is translating this data. So the first step is, of course, having access to the data. And Akin touched on some of the fact that the vast majority of the health centers and health facilities we rely on still use paper. But having access to data is step 1. But it doesn't matter how good and how much data you have if you can't translate it into the format that the decision maker can access. And those decision makers are at all tiers, national government, subnational. You mentioned about how do we get global policy into government. I'd actually like to know, how do we get the frontline community health worker to inform and influence policy? That does mean that that data that's being collected has to be translated into a mechanism that can be in a format that can be used to inform decisions made by people who are not 9 times out of 10 specialists in the subject matter. So I would say that the key message there is making sure that data is accessible by the decision makers at every tier of response and health planning.
Yes,
Yeah, I'll just maybe reflect on the KI Grand Challenge projects, because I think one of the things that we saw in both of the presentations and all of them really today was how the results are aiming at impact and not just a publication. And the partnership between the data scientists who've been a part of the KI Grand Challenge projects, and we see this in Brazil and also in India as well. We see that partnership with ministries of health to see the project that is being funded by the KI Grand Challenges and think about, okay, what could a policymaker or Ministry of Health learn from that? And so one thing that's interesting to consider going forward is what is mapping those challenges and running RFPs like the KI Grand Challenge work so that the Ministry of Health questions that need to be answered by data can be funded by these RFPs and engage the growing community of data scientists that have emerged. So that's an exciting opportunity that I see as I was listening here to the presentations and thinking about how do you map that all the way to the policy impact and bring that partnership together.
Yeah, so for us in government, I think our biggest priority is coverage. If we can get the coverage up, we can deal with the more exotic things afterwards. And so for coverage, as you've rightly pointed out, as decision makers, we need good data, and good data on knowledge, attitude, and practices. What is going on in the community? What is the health-seeking behavior of the people in Lagos State, for example? And then you need to disaggregate that, because it's going to be very different from the more affluent parts of the state into the more crowded and lower socioeconomic groups, and then even into the more remote areas like you have in Brazil, where in the Amazon, you would consider that a remote area. So do we. Lagos is 1/3 riverine, difficult to get to. You have to get on a boat. You have to trek through mangroves and things like that. And there's a sizable number of people living there. So we have a different stratification of population, and each one of them requires a different approach to knowledge, attitude, and practice. And then we've got this growing population of slum dwellers, because people coming in, they have no defined residence, they have no job, so they go into the slums. The slums are now becoming hotspots for disease, and so that in itself is a priority for the government of Lagos State, because in those hotspots of slums, there's reduced sanitation, there's crowding. Anything contagious in that environment, whether it's airborne, contact-borne, waterborne, whatever borne, will spread extremely fast and create a biosecurity threat to the entire community, because like in all developing countries, the domestics and the workforce tend to live in those very crowded areas, and they come into the cities. They come into the more affluent areas. They're cooks, they're nannies, they're drivers, they're low-grade blue-collar workers. And so if there's a hot spot in a slum, it doesn't take long. It's be 24, 48 hours before it spreads into the whole city. So these are priorities for us in Lagos.
Talking last, but let me show you. I don't know. For me, we are talking about scientific knowledge translation, and this is the big deal. We have not to only talk to the policymakers, but also to the populations. We have a big challenge here to really invest in human being. I mean, let's talk to everybody. Let's try to do something different. Let's teach our research to talk in the language that a 5-year-old can understand. That's the barrier that we actually face in COVID, and we are facing nowadays because of poliomyelitis and measles. So we have to face the problem face to face. And also, we have to still go on and look at the future and try to invest in not only primary researches and also secondary research, so we can but combine them. It's about the ecosystem of governments. We have to put that in the policymakers' minds and also in everybody. So we have to be able to pull out our masks and be only human beings, not with PhD, not with masters, not a doctor or a scientist, or we are all together in that. And since we don't face that problem, we are not going to resolve the problem. That's the thing.
Great. Yeah, I think we can take a couple minutes and open up for questions from the audience. Go ahead. Do we have microphones to pass down? And maybe while that's passing down, I know people will start to trickle out as we hit the hour. Just to flag, we will be sharing a survey at the end with any participants. So if you make sure you've signed up on the sheet and done an email, we'll have a slide at the end as well to share that. And Exemplars will be having a session next as well, just in the room next door. So if you want to learn more, you can come join us. But yes, go ahead.
Just a comment. And now all our data system have basically come from a huge amount of people collecting data, going for central, and to provide data for policymakers that in general don't look data. And in my point of view, we as data scientists, we need work in a different way, that is to provide good data for people that collect data, they need this data for the day-by-day work. And when we look, for example, this incredible capillarity that the primary care in Brazil, that Brazil has, at the end, the people that are working at the primary care don't have access to any data that they collect. Then I think that we need to change our perspective to data science not for only policymakers, but data science needs to be made for people that work and collect data.
Yeah.
So I entirely agree with that last comment. And generally want to thank you for a great panel discussion, really inspiring. So I'm Dr Moussa Sarr from DD of data.org. I have a question for you and a comment first of all. So the comment is, carrying on the topic, I think we need to invest much more in a new skill in data science, and that is a skill of creating narratives with data suited to the right audience. Because we mentioned in our discussion many different audiences. There's the policymakers at different levels of seniority. There are the kind of the middle-ranking doers in policy, there are the high-level government officials, there is a general public. All of them have different needs in terms of what the data should tell them. And we're giving them data generically, the same graphs, the same information, and then we are surprised that they either misunderstand it or they take different things. So having this, teaching the skill of creating narratives suitable for the audience, I think is important. That's the comment. The question, I guess, for the panel is, let's pick one of those audiences. Let's say senior stakeholders in policy. What would be the one or two skills you would all wish that your senior policymakers had in terms of consuming data? What that they currently don't, to improve the situation? Open to you.
So I would just say some amount of data literacy and being able to, I think it's a two-way street. I totally agree with you that data scientists need to meet policymakers somewhere down the road and tell what I call data stories, where there's a visualization and it's compelling. And so policymakers need to be able to deal with those types of visualizations and think about asking the right questions. So as a policymaker, what does this mean I should do? So I do think it's some amount of data literacy training and maybe just putting data scientists and policymakers into a room together to work on that communication. Again, that C's coming up and again, figure out a way to talk to each other, speaking a similar language, maybe not the same.
I was going to follow that actually and throw it back and actually say, reflect the words that a politician who won't be named actually said to me, said, look, my job is not to understand the data. Your job is to give me the data that will get me what I want. And the politician's viewpoint is, I've been elected to do X. That's his goal. And that's why, especially in public health, we tend to have very long-term, outcomes are in 10, 15 years. They don't get their elections in 3, 4, 5 years. Their job is to deliver what is going to get them re-elected, hopefully, or some other accolade after their term is complete. So I would actually challenge that the politicians' interests are huge and vast and varied depending on where their sphere of influence is. So as health scientists and data scientists, our responsibility is to understand his motivation and then craft the data to fit that, because their interests and their expertise and capacity will vary depending on what they did before they became politicians. But the goal is what is going to engage you. And if you can craft the information so that it hits that sweet spot, so it says, this person knows what I need, you have an open access, then you can educate them to understand the finer points of the data.
So I think it's also important for academia to understand how government works. In government, you have split seconds. Even when you're in government as a policymaker, everybody is competing for the same budgetary pot. And you've got like seconds to make your point and engage with the people that define how much money goes to whatever program. So you have in the Ministry of Health, you have a budget. Say you have a budget of 100 decimals. They talk about budget performance in terms of how effective you are in drawing down that budget. So when we talk about the Abuja Declaration, for example, where you have to spend 15% of your budget on health, and a country like Lagos is spending 5% of its budget on health, well, that's the budget. How much of that gets drawn down? Probably 20, 30%. So it goes from 5 to about 2%, getting further and further away from the target. And then, you give us data that's so complicated and difficult to process and visualize, and so what we do in the Ministry of Health is I engage a lot of technical assistants to process the data, not only process the data in a way that's visually clear, but then I apply another layer of specialists, which is something that is almost as rare as hen's teeth now. They're called health economists. And in the Ministry of Health, that's who you need. You need data specialists and you need health economists. You don't need anybody else. And if you can fill your ministry with data analysts and data and health economists, you're gone. You're on a fly, because the data specialists will process the data. The health economists will now tell you how to get more bang for your buck. And in that 5 split seconds you have in cabinet to present your case, boom, you're gone.
Yeah, just complementing, it's just like a pitch. When I'm a professor as well, and when I teach my students in management, I always say to them about timing. You have to convince the other. You have 1 second, it's 1 second that you have, and you have to do the decisions. And that's one of our biggest challenge here in my department also, because sometimes I'm there with the Minister of Health and I have to tell them one number that I have to convince him to change what he's doing. So that's my problem every day. So we have to be able to translate the data. That's the main challenge. I mean, it's about policy, it's about evidence, or it's about the impact of what you're doing. That's the bridge. That's what all of us are talking about. So
Just to come back on that, all of you, suggest a skill in data science that's missing, which is pitching and narration for people who have a very short amount of time to take into account. And that's all we're doing as a community as well. So there's a missing skill set.
So we have, I'm conscious of time because we're over, but I know we have one more question. And so we'll do this last question, and then you're welcome to hang out and talk as long as the panelists are willing to stay. It's this room is also a hotspot. Hopefully, it won't be a site of contagion. And I just want to allow
Yeah.
this last question.
Thank you. This has been exciting panel, and I really enjoyed myself, and congratulate the team. I'm interested in target policy profile because my work involves clinical trials in the NDI, and our interest is to ensure that the patients do get the medicines that we develop, and therefore the Ministry of Health has to be able to change policy to adopt the new treatment. So it's in our interest that policy is delivered. So at what point do you develop this target policy profile? And do you, because when we do the TPP on the clinical side, we do it well before even the clinical trial starts. So at what point do you develop your TPP? And also, do you involve the clinicians as well? Is it the project people, a team that develops it? And do you, who else do you involve? Because usually for us, would involve everyone, the stakeholders. What happens in the TPP? And I think it's a very good idea, especially if the two groups, policy and the clinicians, are involved.
Yeah, so thank you for that. And I'll just say that this tool is out there for everybody to use. And we're seeing different groups take it up. And you can use it at an early point. I mentioned that I presented on this in Paris a couple of weeks ago with Ministries of Health from Africa. And the ministers said, use this early. Connect us to your vision and the evidence that you're going to generate, the clinical trials that are going to be funded, so that we have line of sight and so that governments can get behind and support that. So I think engaging your target audience, whether that's a country-based group, a policy, Ministry of Health, or with WHO, and then thinking about, yes, clinicians would be at the table, different stakeholders, manufacturing, pharma might be at the table, depending upon what the goals and the objectives are. And thinking about the importance of implementation data as well. So how do we actually deliver? Ministries of Health are going to want to see that as well. So it's a very group of stakeholders that need to all align up together. And one of the hopes we have is that by aligning early and having all of those stakeholders together, we can really accelerate the conversation and engagement that you have with policymakers, because oftentimes there's a little piece that's missed. It's you forgot the manufacturers. Come back next time and bring them then. And so the hope is that that folks will try it and figure out what parts of it are working. We want to hear back. So we're very interested to learn from the experiences of groups who are taking it up.
Thank you.
Yeah.
Great. I think with that, we will wrap the session 10 minutes over, but I think that's reflective of the really rich discussion we've had today. So join me in thanking the presenters, the panelists. And as I mentioned, if you give us your email, we'll make sure to share materials, the presentations, as well as additional support materials. This is the QR code if you want to respond to the survey, share more of your background, interests, and questions with us, and we can continue the conversation. So thank you, everyone. Thank you to the audience.